My name is Charles Nazarian, and it's my honor to be your host this afternoon as the president of the Gloucester Meeting House Foundation. This event is part of a series in which the Meeting House becomes a civic hub, and in which all of you, as part of our greater community, may get together, work together in a symposium format, have a chance for Q&A with experts in their various fields. And I think we have a pretty amazing amount of experience and brain power here today. So there'll be a lot of possibilities for interaction, and we're absolutely delighted to see you here. Just a couple of quick things. We are simulcast, and the event will be available on video afterwards on the Gloucester Meeting House YouTube channel. So we want to extend a warm welcome to anybody who is watching with us online or in the future. If you could make sure that your telephones or beepers are shut off, that would be very helpful so that that doesn't get into the permanent program. And if you need a restroom, which is always the main question when people come through the door, the nearest one is at the end of this hall, and if that's busy, there are two more down the flight of stairs. And feel free to move around at any time, be comfortable in the course of the afternoon. This event, like the events that we hold from September until May, is sponsored by a group of people who are very dedicated to the work that we're doing in the Meeting House, not only as a civic hub, but as an entertainment venue and a place for community gatherings of all sorts. I'd like a round of applause for all of our sponsors who have made this possible. Events like this also do not happen by themselves, and we have a really wonderful committee of folks who work very hard, first to dream up what the events coming up might be, and then one by one to design them, to invite other people to participate, and then to do all of the in-between work, whether it's programming, the printing, the design, whatever. Lots and lots of hands go into something like this. The head of our events committee is Heather Atwood. Heather, would you stand, please? And several other members of our events committee are here. Jerry Ackerman, please stand. Dick Prouty, please. Wave your hand. Reverend Janet Parsons is not here at the moment, but I think may be joining us later. And the member of the events committee who really took this event in hand is Karen Bell. And I'm going to, Karen? Karen is going to open up for us in a moment or so, but I must tell you how much work she's done to do this. It's really a gift to the community, and we're so pleased that she was able to find the time to do this fine work. So let's welcome Karen and move on with the program.
Thank you, Charles. I'm also on the events committee, as Charles mentioned, and I serve as a trustee of the Addison, Gilbert, and Beverly hospitals. So this is about my 4th year. We have invited today leaders of the Cape Ann healthcare system to talk about how the health of our residents is affected by social and economic forces and what resources are available to improve health outcomes. So today's program will feature 3 speakers first who represent different organizations and healthcare professionals, and perspectives. We will also have a panel with the speakers and 5 other healthcare professionals to discuss solutions to different situations that people are likely to experience. And these are fictitious situations, but they might sound pretty real. And I hope this helps everyone to learn more about available resources, the gaps in our system, and also to generate ideas about how to improve access to needed care. So first, our first speaker will actually help us to understand how did we get here, how our system evolved. And to that end, we'll hear from Paul Lundberg, who is a long-term trustee of Addison Gilbert and Beverly Hospitals, and he also chairs the hospital's Quality and Patient Experience Committee. He wrote an essay called Addison Gilbert Hospital, and it appears in the collection of Gloucester of the essays entitled Gloucester Encounters that was produced for the Gloucester 400 anniversary celebration. He's also served as president of the Gloucester City Council and a council member, and his professional career has been in operations management of both passenger and freight railroads, including the MBTA's commuter rail. So before I welcome Paul, I want to point out the window up here, the stained glass window that's not covered. And that's a window that's a memorial to Addison Gilbert, who was a member of the Universalist Church congregation during his lifetime. So we'll leave that illuminated. And Paul, would you like to speak?
Sure.
You could either come up here or stay there, I guess.
Oh, I'll come here.
Yeah.
Well, thank you, Karen, for the introduction, and Dick, and to the Gloucester Meeting House Foundation. This is the Gloucester Meeting House Foundation is organized this symposium as a civic gift, and it is so important because, as we all know, the quality of life that we enjoy here on Cape Ann is based on many things. A couple of them are affordable housing and health care, and the Meeting House Foundation has done a great job bringing those issues to the public in ways that are meaningful. And I should point out just quickly that healthcare is not a monolith out there someplace where we can't grasp or have any influence on. Healthcare is something that we can influence with our knowledge and be a part of. So as Karen mentioned, I wrote this essay about the Addison Gilbert Hospital for the book Gloucester Encounters. Marty Ray, who's here today, organized that project and got 40 different people from different walks of life to write an essay about something in Gloucester that they knew. So I've taken just a few excerpts, not a lot, just to give everyone a sense of history, how we got here in terms of healthcare in Gloucester. One of Gloucester's first practitioners of the medical arts was a midwife, Isabel Babson, who immigrated to Salem from England with her son James in 1637. As her skills became known, our townspeople enticed her to settle in Gloucester by offering her several grants of land near Good Harbor Beach. Her knowledge, wisdom, and experience became the foundation of the medical practice here. When Cape Ann suffered through our first pandemic, the smallpox outbreak in 1778, treatment was given at home, usually by the family's customary remedies or by people in the community who were known to have some medical knowledge. Physicians with formal training were scarce outside of Boston. The communication of medical information was informal and infrequent in rural areas. Over the next 100 years, medical science advanced, and with the first public demonstration of anesthesia at Mass General in 1846, surgery developed into a safe and viable procedure. In rural areas, much medicine, including surgeries, had been performed, quote, on the kitchen table, end quote, or in the doctor's office. But rural towns came to understand the need for a community hospital where professionals could practice, where clinical and hygienic standards could be met, and where patients could recover under the watchful eye of trained nurses. So on the North Shore, hospitals in Salem, Beverly, and Newburyport were established in the 1870s and 80s. In Gloucester, that effort was bolstered by the bequest of Addison Gilbert, a successful ship chandler, quote, to found and establish a free hospital, to admit patients as may need medical or surgical aid and treatment, end quote. Gilbert's will also stipulated that the cost of care be dependent on the patient's ability to pay, a concept that continues to be in the forefront of medical debate to this day. The Addison Gilbert Hospital was incorporated in 1889, and the original building, which is still the hospital's public face on Washington Street, was constructed and opened in 1897. So that's how we got to having a hospital here. And now a quick little historical snippet on medical finances and costs. Going back to the origins of our medical care in the 1800s, we can see the importance of how care was defined and paid for. The Gloucester Medical Association, founded in 1850 by local physicians, codified the rules about charges based on day visits, $1, night visits, $2, and vessel visits, which was $1.50 if the vessel was inside the fort, and $2 to $3 if it was outside the fort, depending on weather and distance. So that's a place for us to aspire to bring medical economics back to. Finally, many community hospitals like ours had at a time all of the services and were tried to be a full service hospital to all the needs in the community. Of course, as we know, that has changed radically. For instance, at Addison Gilbert, we no longer have surgery or maternity. But we do have a lot of things, and I'm going to end with one comment that is relevant to this picture here about what the community hospital really is. The community hospital has emerged as the gateway to the healthcare system. It can provide equitable access to an increasingly complex world of care where medical information, accountability, and the right to receive care are in play. It is where the most crucial relationship, that simple interaction between the provider and the patient, is maintained. And it is the foundation of teamwork necessary among all of the partner providers. So, thank you for listening to the history lesson.
Thank you, Paul. So our next speaker is Dominique Hurley, and she is the Director of Public Health for Gloucester, joining the department in August of 2023. She has spent her career working with biopharmaceutical and health data companies to improve treatment, diagnosis, and patient outcomes. Within the Gloucester Health Department, Dominique is seeking to understand public health needs and identify areas of collaboration to improve access to health services.
Hi, everybody. Dominique Hurley, Director of Public Health for the City of Gloucester. Thank you so much for having me. It's my pleasure to be here. I hope I get the clicker right. Yay. Okay. All right. So what I'm going, oh goodness, it's not really. Maybe go out of PowerPoint mode. All right, well, we'll have to roll. It's just it's bigger for the, too big for the screen. I think it'll be fine. We should just, yeah. Do you want me to start or? Okay, great. So I have been here since August, and in that time I've been working with my department and bringing in a lot of missing headcount. And I've had the opportunity to meet with community organizations, not as many as I would like, but I keep chipping away at them. And I'm going to have an opportunity soon to engage with most of them, I hope, if things go well. But as I've met with these community organizations and residents, I'm hearing almost unbelievable anecdotes about access in Gloucester and healthcare access in Gloucester. And you can see that we're not alone. Over a third of the country is having barriers to access, looking at 40 to 136 days. Throughout this presentation on the right, which I hope you can see that back there, are quotes from people that I've spoken with across the city. And I'm using them to provide anecdotal backup for some of the facts that I'm going to be giving you. I am going to be presenting some findings from our public health sources on the state of healthcare in Gloucester specifically. And then I will talk a little bit about what our department is doing to support some of those services and some future work that's coming up. But back to those unbelievable anecdotes. One of them that I heard is that there's a 400 patient wait list at one of our health organizations, that students are missing their traditional immunizations at a pretty big clip, and in particular, meningococcal compliance, so getting your vaccination for meningitis is a pretty significant concern right now in the schools. We all know that COVID created a backlog of wellness visits, and routine examinations are sort of lagging. But what we're also finding out is that people are having changing HCPs with no notice. There's language barriers that are sort of inconsistent ability to handle people that have English as a second language across our practices. There's lengthy response time for case follow-up. And these dynamics seem to be prevalent in every single conversation that I have. One of the ways that I'm going to be approaching our talk today. No, it's not working. The clicker's not working. There we go. Yep. So we're going to be focusing on social determinants of health as a metric here, and in public health, social determinants have been proven to be a factor that are driving healthcare success and well-being in our community. We're focusing on a few of them. Under the employment side of things, we're looking at employment status, primarily in income and its impact on our people. Work-related resources such as insurance. Looking at community design as well in terms of how our practices and healthcare access are serving across our city. So I think I'm going to read the quotes if you don't mind, because I don't know if can you all see the quotes on the top there? Can somebody nod yes or no? I'm just going to read it to you. So as it relates to primary care access, the quote is, "There's a wait list from weeks to months to see patients, and we have difficult time getting the information that we need," and that's a public health nurse giving that information. The graph here demonstrates some findings that we have from HRSA, or the Health Resources and Services Administration, which is a division of the Department of Health and Human Services. This slide in particular is addressing primary care access. Do I have a medical home? Do I have a physician that knows me? Do I have a relationship with that physician that I go for both wellness as well as sick visits? In our city of 30,000 residents, we have about 21 primary health care providers per this study, which is about one doctor for every 1,400 of us. And that puts us about 30% below state averages and 4% below the nation. These numbers are below even rural Massachusetts hospitals, where the mean is about one physician per 1,100 residents. In a recent study requested by Governor Healy on the impact of rural hospital closings, losing a sole hospital in a rural area, and in this particular case that they were describing, it was a population of 33,000, which sounds very familiar. They saw almost a 19% attrition in physicians while the hospital was shutting down, as the hospital shut down, and then after the hospital shut down. And if we do the math that I just described for you, that would be 2 to 4 HCPs, or about 6,000 of our residents that would lose access to physicians, a fifth of our population. So in the health department, what we're trying to understand as we look at this data is what's the impact of regionalization? So we're not necessarily closing out Addison Gilbert, but certainly services are moving away. And what is the impact that those services moving away is having on the ability to attract physicians, to keep them here, to make sure that we have the access to health care that we need? Of course, telemedicine is making a difference now in our world in terms of access to care, and certainly nurse practitioners are increasing in their service in the primary care world. However, as you'll see shortly, there's other drivers that are impacting this as well. So I want to move on to mental health access. And the quote here is, we need mental health providers, but we're not funded for full-time support, so it's very hard to keep clinicians. And that comes from a community organization. And probably every single community organization I've spoken with so far has said the same thing. It's a very big need in our city. In Gloucester, we have, per this same study, about 186 mental health providers, which means about 1 provider for every 159 people, which sounds a lot better than the number we just talked about. That number doesn't sound so bad, but again, 100% of the community organizations that I've spoken with have brought this up as a gap. So we'd like to learn more about the caseload per provider and where these gaps are coming from. If we look at 6 clients a day, it's about 40 patients a week. That's probably on the high side. Other studies say 15 to 20 clients at any point in time for a mental health care provider. But we know we have high burnout rates for those people that are supporting, and we have low funding levels. So our mental health providers, very important to the entire community, are underpaid and overworked. And there's too many patients, obviously, than they are able to serve. Moving on to addiction and substance abuse, the data goes on to say that there's about 7 providers available in Gloucester. I think it's a little lower now, given that the Addison Gilbert had moved away some services, but I heard just today from a meeting yesterday that we're actually going to be bringing some back to Addison Gilbert, which is really terrific news. But we're 23% lower than state, and we're lagging national averages as well, as it relates to our ability to support this very specific need in our city. And we have a pretty sizable problem. Excuse me. And the quote again is up to 40% of all hospital beds in the United States are being used to treat health conditions that are related to alcohol consumption. And the exception there is, I think, maternity or critical care. So it's a big drain on our system as well for not being able to treat these folks. If we're looking at clinical care access, and in this case I used emergency room visits as a proxy, and I'm using Medicare and Medicaid data, so that's people over 65 or those with disabilities. We're doing about 3% better than the state, but we're lagging national averages by 6%. So the health department would love to learn more about the dynamics in Gloucester and what's driving this high ER rate. I think some of it's pretty predictable, but the stories I've heard, again, calling an ambulance because they don't have transportation. Calling that ambulance because they can't get in to see their PCP, being turned away from urgent care because they don't have proper insurance. We have excellent transportation services in the city through CADA, through Patient One, and through, I know the hospital systems will, pick you up from the end of the line on the T and take you to their campuses for centers of excellence. But I also know that the seniors are not necessarily taking advantage of very many of those. I just had a call the other day from somebody at CVS, a pharmacist, who's saying that there's a significant drop in compliance among those that are over the age of 65. They're simply not coming in to pick up their meds, which is a concern. Finally, moving on to ability to pay, this data goes on to talk about how 50% of our residents are on public health insurance. 50% of our residents are on public insurance, 25% higher than the entire state. We wonder, when we look at that metric, about practice turnaway rates. Are we getting access for those folks for specialists and centers of excellence and facilities where they might want to go? More importantly, 3,000 of our residents are not insured at all. And what we're trying to figure out on that one is where are they and how can we find them? We know that the folks from SHINE do a terrific job at annual enrollment, helping folks make decisions on Medicare and Medicaid. So senior care, council on aging, I think Fishermen's Wives and other groups are stepping up to support that. But where are we in reaching these residents and trying to get them the insurance coverage that they need? These were fantastic slides. I'm sorry you can't see them. If we look at poverty statistics in our city, I don't think anybody will be surprised by this, but about 3,000 of our residents live in poverty. And if you're under the age of 18, that's 20% of people under the age of 18 are living in poverty conditions in our city. These metrics are much higher than those that are state and local averages. Other factors to consider, 4.8% of our city residents are not US citizens, 2.1% don't speak English, 9% don't have a car, another 9% don't have internet, and 20% of our residents are paying over 50% of their income for household costs. We want to learn more about wellness and sick visit implications when so many people are struggling for basic necessities. So let's talk about what we're working on. First, there's another slide here in a later rev that's not here, so I'll just review really quickly with you what we're doing in the health department from a services standpoint to support healthcare. On the public health side, we, of course, are providing all of the vaccination clinics that you probably are all reading about, and I think we could probably do a better job of promoting, which we're going to be working on in this year. We also do all of our communicable disease tracking and making sure that we're keeping up with any Maven case that we've been alerted to. So if anybody has a communicable disease, we find out, our public health nurse follows up and makes sure that we try and manage that case and stop and ensure that we don't spread whatever is in that person's body. We have visiting mothers for those new mothers, bringing diapers and education services. We're providing public health education on matters that we hear about from the CDC, from the state as well. And we're also providing agnostic assessment of opioid dollar remediation allocation. So all of the monies that are coming from the pharmaceutical companies as it relates to opioid, the mayor's having our department assemble one view of it across all community organizations so that we can align and collaborate on how those monies are going to be spent. On the prevention services side, we only support youth prevention. We are all grant funded. We don't have any real access out beyond that, but we're running a Gloucester Youth Leadership Council that teaches students how to have a lifestyle that doesn't necessarily include substance abuse. We have speaker series. We're educating the entire 10th grade class in our city on mental health first aid, how to spot it, how to address it, what to do. We're helping our police force and the community impact unit have training on trauma-based engagement, and the list goes on. On the public health education front, though, I want to just give you all a heads up on avian flu. We just had a briefing from the DPH and CDC. Avian flu has crossed into mammals. It's now in cows and goats down in a few states, including Texas. It's in their milk in really high viral count, and people that have been treating those animals have gotten and contracted avian flu. It's H5N1. And so don't eat or drink unpasteurized milk or cheese for a while. Just little public health message there. My last slide is what we're working on now. And so I have, as I said, been trying to meet with many of you in the community to find out what your perceptions are of what we can do in our department to make a difference. And we've just launched a project now, finally contracted, and the mayor gave us some ARPA dollars to support this, where we're going to be building on all of the needs assessments that have already been done. We're going to be meeting with all of the community organizations and residents and city officials to talk about the findings that we're synthesizing, hopefully elaborating on that and really getting to some very specific places where we have cross-organization synergy. And then that will in turn lead us to help form a strategy of what the health department can do to build a service set that doesn't replace or try and equal, but complements things like driving dollars to our community organizations, supporting effective communication and collaboration across those groups. And I really don't know what that's going to look like yet because we really have to hear from you all, but we're looking forward to it. And in the month of May, most likely, we'll be reaching out to a lot of you in this audience and asking you to come and speak with us and let us share what we found and get your input. So thank you very much for your time. And hopefully, if you want to get involved in this project, I would love it. So please reach out. Thank you.
Our next speaker is Margaret Brennan, Maggie Brennan, and she is the president and CEO of the North Shore Community Health Centers. And in Gloucester, the name is Gloucester Family Health. For the past 13 years, she has extensive experience leading other nonprofit and public health organizations. She has overseen an expansion of services at the health center, including behavioral health services and outpatient treatment for people who struggle with substance abuse, including opiates and alcohol. So welcome to Maggie.
Thank you. Good afternoon. So glad to see people who came out on such a beautiful day. We're competing with the weather here, which is always tough. So thank you all. I just wanted to walk you through a little bit about what are community health centers, because probably many of you may not know about us. I feel like we're the best kept secret in the country and in Gloucester. And then tell you a little bit about some of our services and tell you about what we're seeing within our patient populations. So you can go to the next slide. Thank you. So community health centers grew out of the social justice movement in the 60s, the Great Society, right? And actually the first one was born in Massachusetts, in Dorchester. And Teddy Kennedy, our own Senator Teddy Kennedy, was instrumental in getting funding, federal funding for community health centers to expand the model. Because communities all across the country were coming together and saying, hey, we all need access to care in our neighborhoods where we live, and that was really lacking. Or when they had it, the care wasn't terrific. People felt like they were discriminated against. They weren't getting what they needed. So that's how community health centers were born. So today, we have 50 community health centers across the state of Massachusetts. We serve 1 in 7 Massachusetts residents. And in the country, we serve more than 25 million people. So what we do at just a little bit about what we do before I get into North Shore. So we raise our hands to step up to meet community demand when and where we see it. What do I mean by that? Well, a prime example is the work that we're doing and have been doing for almost 10 years around substance use disorder treatment. We saw in the teens, when I first got here actually, and when we hired our first chief medical officer, that there was we were in the midst of a huge epidemic which was just growing around opiate use disorder. So we raised our hands to step in and take care of people in the community. So we actually, for our size, have one of the biggest outpatient opiate abuse disorder treatments in the state for community health centers. Because we step in as needed, right? We also partner with public health. What do I mean by that? Well, another great recent example was in the pandemic. So we're relatively small. We don't have a huge staff. We had patients who were sick. We had to take care of them. But what we could do during the pandemic was identify and work to test and treat highly vulnerable populations. So we worked very closely with Action Shelter here, and then the program that's right downstairs in the basement, to make sure that folks who were either residents of the shelter and the staff were getting tested and vaccinated during the pandemic. Because we thought, we were thinking what role could we play given our size? That's what we could do. So we stepped in and worked very closely in partnership with the health department to make sure that the community's most vulnerable residents were protected. So that's just an example of what community health centers do. Next slide. About us. So our mission is to build healthy communities by providing exceptional care to all. I'll talk about that in a minute. Our vision is when we have healthy people, we have vibrant communities. And these are our values, and we really take these very seriously. They don't just live on a piece of paper. It's how we treat each other as staff in the building, and how we treat our patients. So I think we take these values very seriously. Next slide, please. So we were actually born in Peabody in 1977. Oops, I'm on the wrong page. Sorry. And Gloucester Family Health Center is almost 20 years old. We opened in 2008. So we're open to all, and we're dedicated to primarily serving basically anybody who walks through our doors, regardless of insurance or ability to pay. That's sort of that's our jam, that's our space. And the model that we do is very comprehensive. We seek to be one-stop shopping. What does that mean? Well, you can see your primary care provider. You could go downstairs and get a dental exam or get cavities filled, and then you could maybe see, if you had a therapist, you could see the behavioral health provider in the building. So in addition, as I said, we have a pretty significant substance use disorder treatment program that we're very proud of. So it's a very comprehensive model. We also have full-time sites in Peabody and Salem, and we have school-based health centers at Salem and Peabody High School. And then we have, whoa, am I done? Okay, wow. Well, I'm almost, I mean, you know. That's okay. Makes me feel so special. But we also have behavioral health staff who are outposted in the middle school and 3 elementary schools in Salem. Again, that's another example of, in the teens, I guess it was, we saw an increasing demand, which is now crushing, for behavioral health services, particularly those for kids. So we work closely with the mayor and Salem, and we're able to hire some therapists who are posted in the schools in Salem. Next slide, please. Now, what we're seeing, so continued high demand for our outpatient substance use disorder treatment. What are we doing in response? Well, we have basically same-day access. So when somebody is ready, they've raised their hands, I want to start treatment, we can be there. We're there, when people need it. Primary care demand is high and increasing. That's not going to change anytime soon. During the pandemic, we flexed and ran hard at telehealth because we wanted to make sure our patients were well cared for. We've stayed pretty much in that space. We find that our patients really like it. We're doing a lot more video visits. Gives a lot more flexibility to both our patients and providers. So we're doing a lot of telehealth still. Additionally, I'm proud to say that we have nurse practitioners who are on call evenings and weekends. So if warranted, our patients don't just get a phone call back. If something's going on and one of those nurse practitioners wants eyes on our patients, we can do a visit. And they are doing visits. They've done visits in the middle of the night if it's warranted. So I think that's a pretty excellent care model. In addition, I think behavioral health demand is obviously skyrocketing. So we're continuing to try and meet the need, as everyone is, right? But there just isn't enough. There isn't enough supply. So we're looking very closely at the supply that we have, making sure that because of our model is behavioral health, integrated primary care and behavioral health. If we have sufficient supply, however, to help to meet some of the skyrocketing demand in the community, we'll step up and open our doors for folks who need access to behavioral health. We just need a little bit of time to assess whether or not we're able to do that, but that's one of the things that we're thinking about. And then the other thing that we're seeing, and to a point that Dominique raised, is some of the drivers of healthcare, health outcomes in the community. 2 of the biggest ones that we're seeing, because we're screening folks for it, is food and housing insecurity. Food insecurity, we do a pretty good job working with all of the food service agencies up on the North Shore and in Cape Ann. I think they're all doing pretty well. They're doing a terrific job. Housing is painful, as we all know. It's hard to screen somebody to find out that they're housing insecure and not have someplace to send them. So we're working closely, any advocacy efforts to continue to build affordable housing in all of the communities that we're in, we're involved in that. So I think that one might, oh wait, one more on the future of primary care. Sorry, last slide. One more. So what's coming, what's already here is in-home primary care. We're already doing it with telehealth visits. We're going to deploy clinicians as needed to get to our patients who aren't able to come to us. You'll see that more and more. You'll also see that with ED visits. People are going to be seen by clinicians in their houses increasingly. There's already remote patient monitoring. You'll just see more and more of that, particularly as the workforce issues continue to impede our ability to have people come to see us. We'll go to see them. Well, you'll also see more nurse practitioners and physician's assistants instead of MDs. There aren't enough docs going into primary care. And nurse practitioners and physician's assistants can do a pretty good job. We've been working with those folks for quite a bit, and I think you'll just see more and more of that in primary care. And, we certainly hope to see more resources directed to meeting the non-medical needs of our patients, because as I said just a minute ago, we see a lot of the drivers are things that we can't help within the walls of our exam rooms, right? We can't help it if we can't grow housing overnight, so nor can we provide folks with food right in the exam room, but if there's a great service provider, as we have in Gloucester, we can refer our patients. So that's us. That's me. Thank you all again so much. Do we step away?
Yeah. Thank you, Maggie. And I'm just going to remind everybody we'll have time for some questions and answers for the first three speakers immediately after Kimberly Perryman's presentation. And Kim Perryman, our next speaker, is the Senior Vice President and Chief Nursing Officer at Beverly Hospital. She has over 3 decades of experience in patient care delivery and has held leadership roles in both academic and community hospital settings.
Thanks, Karen. Hi, everyone. It is a beautiful day. Does this work? Yes, bottom one. Okay. So I'm going to pull back a little bit and just talk about 4 topics that are higher level than the specifics that both Maggie and Dominique went in more detail about. But was interesting when I was listening, we didn't rehearse. I don't know if I should say that out loud, but there's similar threads through their presentations and a couple points in these next few slides. So I think it is a tribute, really, that we're kind of all on the same page trying to knit this fabric together to take care of communities. So we'll talk a little bit about the health system that we're part of, talk about health priorities in the community, talk about workforce, how could we ever be talking about healthcare and not mention workforce, and then what's new in healthcare. So 5 years ago, Addison Gilbert and Beverly Hospital became part of Beth Israel Lahey Health, and that was the first week in March, and probably that next week is when the pandemic happened. So we came together, and immediately we had to figure out who we were. We didn't actually have time to do that, but we had to figure out how to take care of patients. And when I look back at that, and there's many other folks who worked at the hospital during that time, I don't know how we would have done that not being part of a larger system. There weren't enough masks, there weren't enough precaution gowns, there weren't enough ventilators. But being part of a system, and we met multiple times a day, we were able to bring the resources to different communities and different patients. So when people ask me, what's it like being in a health system? You can always throw the flag on the play when you need something and know that you have a resource behind you. So I guess we're better together is how I would frame that the time that we're in now. So keeping care local, being part of the health system, understanding that it's so important for communities to have access to care. I'll tell a story that, I grew up in North Andover, and anytime, not too far from Boston, anytime anyone was sick in my family, if you broke your leg or needed your appendix out or had a very complicated cancer diagnosis, you got in the car and you drove down 93 and you went to Mass General Hospital. We've learned now through the past several years that community hospitals can give really, really good high-quality care close to home. You don't have to go into town. The other part of that is understanding the importance of making sure every hospital isn't everything to everybody. When people have a traumatic event in the community or they're very, very sick, clinicians often refer to that first point of care in an emergency department as the golden hour. And community hospitals play a really, really important role in that golden hour, stabilizing someone, making sure that they're getting life-sustaining treatment, and then moving them to the specialty place that they need to be. So I think that's just a really great example of how we are caring for our communities and the importance of community hospitals. Having a shared medical record is another point that's very important. That thread of information clinicians can access no matter where you are in the health system. So just another point about that. So I can't take credit for this slide. Jason Andre, who's here, the Vice President of Addison, this is his slide. But this is a really, I think, important slide to look at the foundation of what Addison Gilbert is. So we just talked about serving our communities. It really is this bottom foundation here that the services that Addison provides, emergency services, inpatient and acute care, behavioral health services, oncology, medical specialties, geriatric care. That foundation is really caring for the majority of the community. That's very, very important. That next kind of middle tier is some other added specialties that Beverly Hospital provides. So OB care, special care nursery for infants, advanced critical care in the cardiac cath lab. So not every patient needs that, but when they need it, we have it here in our system. And then the very tip of that is that smaller point that's being held up by Addison Gilbert, if you will, and that's for the specialty care, whether that's at Leahy in Burlington or Beth Israel Deaconess Medical Center in Boston. That's where the specialized, advanced, complex, research-based care happens. So being part of a system, we're able to access all those things. So how do we identify the community needs? And this is the part, as my colleagues were speaking, we mentioned a lot of the same things that we're really working on to provide for the community. So every 3 years, there's something called the Community Health Needs Assessment that's done. Mary Lou Hardy is our Community Benefits Manager, who's sitting right up front. And that assessment really looks at what the needs are in the communities where the hospitals are serving patients. So it is a state and federal requirement, but it's rich in data, both qualitative and quantitative, and it directionally helps us figure out our strategic plan to make sure we're providing the best care for the most residents in that community. So here's the health priorities from the last Community Health Needs Assessment. So we've talked a lot about access to care. That's what this symposium's about, understanding what that means to different people. Social determinants of health, Maggie mentioned housing, that's something that stands out right away, as well as food insecurity. And, you know, food insecurity, we have lots of programs and wraparound services, but the housing dilemma is still real. That's something that we have to work together and figure out how to make that better. That's what creates that safe, healthy environment for patients and citizens of the Commonwealth or the communities to really thrive. Behavioral health and substance use disorder, particularly in the youth. We also mentioned that the Discover program is coming back to Addison Gilbert after not being there. So ensuring that we have those right services in the right place for patients is very important. And then complex chronic conditions. So both oncology, so cancer diagnoses, and diabetes are two of the top things that came out of that assessment. So we now look strategically at how do we provide those services for our community. So here's an example of how we're doing that. And over the past 5 years, this is a list of providers that we've added to the services at Addison Gilbert Hospital. And if you look at it, it really points to what we found in our community health assessment, along with some other things. So oncology, that was one of the things in that community health assessment that we knew we need to continue to provide high quality care. Different specialties, wound clinic. Wound clinic is something that's very labor intensive for a patient to manage. There's frequent visits, seen multiple times, so having a community-based clinic that focuses on that is very important. Pain clinic, in that lighter color is healthy aging, so senior care and understanding the importance of senior care and geriatric care in our community. In that community needs health assessment, the majority of citizens in Gloucester and on Cape Ann are over the age of 65. So we have that information and we need to direct our resources to that kind of care. and then the surgery clinic that's here. And I would add that surgery isn't just in the operating room. There's surgical care that happens before someone goes to the operating room. There's surgical care given by a surgeon that isn't necessarily always ending up in an operating room. So there's that whole continuum that we have to make sure we keep in mind. So understanding the investment that's been happening at Addison Gilbert over the past few years, over $12 million, which is a great investment. I will say that when I look around this kind of rainbow-shaped facilities and infrastructure is really important. And it's not something that is really cool or programmatic and make a big splash, but that's things like plumbing and air handling units and flooring and those kind of things. And just even being in this historic building, understanding that the hospital brick and mortar is very old as well. So those infrastructure things we have to continue to invest in. Cardiac diagnostic suite. The senior adult unit is a specialized geriatric unit on the campus of Addison Gilbert. Initially it was 12 beds. We saw that community needs, and it's been expanded to 20 beds. And then diagnostic equipments, including CAT scan now on the campus. So Maggie mentioned workforce, and I'll take a couple minutes and just talk about workforce. There probably isn't a day at the hospital that we don't talk about workforce, whether it's a radiology tech, physical therapy, phlebotomist, nurse, and even provider. You know, the pandemic happened and people ran to the fire, right? They were like firefighters, and they cared for patients, and they did a fabulous job. But compassion fatigue, moral distress, there were some other things that were byproducts of that pandemic. People retired early. People left the healthcare profession altogether. So that left this void in the workforce, and like I said, in all different positions. So most recently, we have continued to see those challenges in the nursing workforce. So we've developed new ways of training. And if you think about it, during the pandemic, you know, I was talking earlier in the back room before we came out, and the two industries that were really impacted, higher education and healthcare during the pandemic, right? So these students are in school and they're learning on a screen. They're not touching things. We saw nursing students graduate from college who had never been in a hospital before. So enter into the workforce, and we're saying, oh God, we have to do something differently. So how do we move and change and be nimble and change how we train people? Academic partnerships, understanding that who our colleagues are in the academic world is really important to create pipeline programs. North Shore Community College, Endicott College, Essex Tech, many colleges in the area that we partner with and have students come while they're learning in the hospitals. A quick story before I advance the slide. You know, we've never had high school students working in the hospital before. We've had plenty of college students work in the hospital over the years, even pre-pandemic. And this last semester, we partnered with Essex Technical School. So junior and high school students who are around 17 years old had taken the Certified Nursing Assistant exam, so they were able to come and work in the hospital. And we've had 12 students, a couple are at Addison Gilbert, a couple are at Beverly, and they have just been fabulous. They are full of energy, they are young. I think they've actually been a little motivating to the staff that they're working with or standing next to. I heard another comment the other day that they're always on time, and someone said, well, that's because they don't drive. Some of them don't have cars and drive, their parents are driving them. So I was like, well, there's something we learned. We might have to do more of that. So, but wanted to share another success story, and I'll just orient you to the slide. So an emergency department that sees almost 15,000 visits at Addison Gilbert Hospital, and then the other emergency department at Beverly Hospital, had the nursing workforce be very impacted by the pandemic. So about 2 years ago, we had close to a 60% vacancy rate of nurses in those emergency departments. So the nurse leaders got together and said, we have to do something differently. And I referenced the nurses coming out of school who had never even worked in a hospital before. So we got nurses who are like educators that we employ in the hospital, and we created like a cohort program. So 6 to 8 nurses coming together, learning in the classroom at the hospital, and then going out together like they would have in school, learning emergency medicine, emergency nursing. What we found is that in the past 2 years, we've hired 42 new grad nurses into this program, and now there's a waiting list for May of 2025. And if someone had told me we would hire new grad nurses into a specialty 5 years ago, pre-pandemic, I would have said there's no way we do that. You just don't do that. You have to, slowly work your way into that. But we had to do things differently, and this is actually working. Another slide just showing the importance of making sure that we continue to be market competitive in our wages. That's something that we do on a regular basis for all positions. That's very, very important. Other benefits that aren't necessarily an hourly rate or wage, but things like tuition reimbursement, loan forgiveness, scholarship, all different kinds, almost a menu that can meet any of the colleagues' needs. So what's new? I think interesting, I think everyone talked about telehealth up here, and again, we didn't rehearse the slides, but telehealth really exploded during the pandemic, right? We couldn't go anywhere, but people still needed care. So telehealth really exploded, and it's not going away. It's a way behavioral health, substance use, check-ins, primary care. There's all kinds of application for telehealth, the right application. So understanding that will be, I think, here to stay, and it really just crescendoed during the pandemic. A new program that's happened now and came, I think, more from the West Coast, and it's made its way to the East Coast, is the Hospital at Home program. And this program is unique in the sense that a patient comes to the emergency room at Addison Gilbert, and they have the right diagnosis, whether they need IV antibiotics, they have some congestive heart failure and may need a diuretic and to be watched more closely. They would normally get admitted to the hospital, right, in the brick and mortar, in the bed, in the hospital. There's now an option for the patient to say, you know what, I want that care in my home. So what would happen? I was getting admitted, I need antibiotics, I meet the criteria. Physician says, I'm going to care for you. Do you want to enter to hospital at home? Yes. So a little van goes to your house. They set up all the tele-equipment, the monitors, the vital sign machines, and the paramedics are there meeting you when you get to your door. They see you multiple times during the day, and you do televisits with the physicians and nurses through your stay. And we've had great success with the program, both at Addison and Beverly. Since last November, we've admitted over 60 patients. And one of the things, that kind of byproduct of this program is, one, it's great for patients. They get to stay home and sleep in their bed when it's appropriate and when they agree to do this. But another byproduct is we always hear about overcrowding in emergency rooms. Those 60 patients didn't have to sit in the emergency room and wait for a bed to go upstairs or sit in a bed upstairs in one of the inpatient units. They were able to be cared for in their home. So it's helping in another way help the overcrowding issue in our emergency departments. There was a story I heard of a patient in their early 60s, right when the program started in November, and it was the day before Thanksgiving, and they were going to have to be admitted and miss the holiday with their family. They actually were able to go to hospital at home, were able to be home for Thanksgiving, and had all the services there in the home caring for them. So just an example of how kind of out-of-the-box thinking is changing how we deliver care in communities. And I think that is my last slide, so thank you for your time. Thanks, Karen.
So, thank you. Now, we have a chance for questions from the audience for any one of these 3 speakers. And after that, we'll have a short break for refreshments. Let's see, we have 2 people who are going to facilitate with a mic so everyone can hear, and this will be recorded. Okay? So All right, any questions? Yes, on this side. So just state, who is the question for, and state your name.
I think the question is for those affiliated with the Addison Gilbert Hospital, but it's basically a public health question because we believe, I'm the chair of Partners for Addison Gilbert Hospital, which was formed back in 1995.
Wait, excuse me, your name, just state your name because this is
My
being.
name is Peggy O'Malley.
Okay.
I'm a registered nurse. I'm now retired. I understood you to say that you and the board of Addison Gilbert and Beverly have now see the role of Addison Gilbert as a gateway to the larger, to care. And I think that differs from what the people in Cape Ann who rely on the hospital think, where they think of Addison Gilbert as an absolutely essential hub of services. They have for generations been able to go to Addison Gilbert and receive on those premises all of the care that they needed, except in extraordinary circumstances. We have seen the elimination of surgery over the years. We have seen the elimination of maternity services. And most recently, at the onset of the COVID epidemic, we have seen the closure of our ICU, which is a terrible blow to us in terms of access to care. There are people in, I think the public health data that were shown show that we have a community that's in great pain and is suffering tremendously because of lack of access to care for whatever reason. Some of it is geographical, some of it is financial. But I know, but this is the impact of Addison Gilbert on the
Okay.
public health.
So excuse me, do you have a question, Peggy?
I have a question as to why we have to face the ongoing elimination of what are essential services that are required to be in the building to operate a full-service emergency room, and no one in the public is notified of this, and including the elected officials or the people who are responsible for public safety.
Okay, thank you. So would you like to answer?
I can try.
Yeah.
This is on. Hi, Peggy. Nice to see you. I think the graphic of that triangle of the community hospital all the way up to the tertiary setting, I think is a really important graphic. And I would describe any community hospital, particularly Addison, as foundational, right? And without that strong foundation, you can't have those other parts of that pyramid. So, you know, Addison Gilbert is strong. We're hiring more physicians. Jason Andre's here. He's going to be on the panel again to talk more about that. We're investing in the infrastructure. So we're doing those things to continue to keep Addison as a foundational part of the health system. The other part of Beth Israel Lahey Health is the philosophy is to continue to have care in the community. So the goal by 2030 is to have 70% of the care delivered in the community, not at large tertiary hospital settings. Right now, it's about 40%. And I don't know another health system that has that goal, that understands how important the community hospitals are. So I hope that gives you some framework or answer to your question. So we're continuing to have workforce challenges, and that is the reason why it's unoccupied right now.
The system is having workforce challenges, but all the other hospitals, including the other community
Yeah.
hospitals in that
Okay.
system, have their ICUs open. Only
Yeah.
Addison Gilbert's ICU is closed.
Okay,
We'd like to know when it's going to reopen.
good.
So-
Are there, do you want to respond, or?
I
then
just
we
was going to
time for other
emphasize
questions?
the workforce challenges, and I would also add that there are no patients in the ICU today. I don't refer to the ICU as closed, it's unoccupied. And I think what we also know, and we could have a whole symposium on financials, we cannot continue to use travel nurses to staff our hospitals. And that is a problem right now. We continue to have travel nurses, both at Beverly and Addison. That's why this workforce thing we're in isn't going to be a quick fix. It's a long-term problem. The cost of those nurses are just astronomical, and it's unsustainable. And we continue to have double digits of traveler nurses in both those institutions.
Okay, another question in the middle?
Raja Shamas, quick question on the workforce development. So do we have a sense of how many nurses have left the bedside, and what's been done, if anything, to be able to bring them back into the workforce?
Mm-hmm. How much time do we have? As far as an absolute number, I don't know that I could say an absolute number and feel good about the number I told you. We've had high vacancy rates, you know, as the example, the emergency rooms I gave to you at 60%. You know, understanding that we used to call workforce challenges recruitment and retention. We've flipped that. We call them retention and recruitment. So how do we understand and wrap our arms around the needs of the workforce to create a resilient, respectful work environment for them? And that's the work that happens now every day. So understanding that it's not, again, I feel like I'm repeating, it's not a quick fix. Massachusetts graduates about 5,000 nurses every year in the schools that are here. Probably just 3 hospitals could use those 5,000 nurses very quickly as people are aging. But, you know, I think things like loan forgiveness, tuition reimbursement, career growth opportunities in an organization is awfully important as well. We have programs now that I mentioned the Essex Tech with the nursing assistants. We have nursing assistants now that can take their prerequisites to go to nursing school for free. Loan forgiveness and scholarship opportunity also for them. So we're doing all those things. I don't know that there's one thing to be done to get people to come back into the workforce. I think it's a whole bunch, it's a whole menu of things to meet people where they are.
Okay. Another question over there? You were waiting earlier. No, left, Charles. Other person.
Hi, I'm Nancy Koppelman. I just wanted to thank you all for a fabulous, symposium so far. So I just had a question around cognitive health, brain health, and with the epidemic around dementia, Alzheimer's disease, and other related dementias. What is your plan to address those issues with folks?
Who are you? Who would you like to answer the question? And then you should wait for the panel because we will have other experts later.
Yeah.
Anyone who would like to answer that?
I actually would make
Okay.
a plug for the panel because Dr. Argento is here in the audience, and she's a geriatrician and could probably answer that in a better way than I could.
Good. Okay. Behind you.
Oh.
Behind you.
Hi, my name is Erin George. I actually work at Action here in town and wanted to ask a little bit specifically about behavioral health. I think Maggie and also Addison Gilbert Hospital have been incredible partners to the work that we do, but I think it's a challenge that we're increasing to see. We're a community action agency and are looking to respond in whatever way makes sense for us, but I wasn't sure if there's any concrete steps that either North Shore Community Health or Addison Gilbert Hospital is taking to kind of fill that void. It's something we're seeing time and time again. I think we saw the departure of the high-risk intervention team at the hospital, which was a critical resource to some of our most vulnerable residents. And while the inpatient social work staff is phenomenal, there's a void there that didn't exist before. So I'm just curious what steps you see. Obviously, the workforce is huge, but are there any concrete steps? Hearing Discover coming back is incredible news. But what are you guys doing, I guess, in that behavioral health realm to kind of address those needs as we're seeing them increasing and no end to that in sight?
Boy, that's a big one. Okay. Well, I'll start, I guess.
start, and I'll go second.
Thank you. Nice to see you, Aaron. We have to acknowledge that there are huge workforce challenges, first off. Secondly, I think you have to look at, and we have taken a deep look and are continuing to look at making sure that the job itself feels satisfying and brings joy to the people who are doing it, because that's how you retain, right? So we're doing we're taking a whole lot of measures to try and retain our staff, trying to be as flexible as we can with the staff we're able to recruit, but not at the cost of, patient care. What do I mean by that? It means that a lot of the behavioral health clinicians have gotten used to a lot of telehealth. In our model, the warm handoff is really essential, and it's one of the measures of success in someone showing up to the next appointment is if you can meet your therapist right then and there. So we're trying to figure out a way to successfully get our clinicians back into the health center on some of the days so we can do those warm handoffs while also providing as much flexibility, again, not to the detriment of patient care, the quality of patient care, so that they can also do telehealth. But we also have made a significant investment in starting salaries for behavioral health clinicians, specifically social workers, and this was actually a couple of years ago, because we looked at the market data and it's pretty appalling what folks were making. So we really made a significant investment. That's helped us to recruit therapists to the health center. We're going to continue to look at that because I do think that it's important to continue to keep up to market. But market for those positions was unforgivably low back then. And we wanted to be market leaders. We made a significant investment that helped us to attract people in, but now we got to retain them and we got to attract more. So. I don't know if you guys.
I just have just two comments. You mentioned Discover returning. Yes, we're super excited about that from a behavioral health perspective. And the other thing you mentioned was the high-risk intervention team. And this is breaking news, really, that we have a grant, so we're bringing those services back. So you'll be hearing more detail about that.
That's great.
Good. Thank you.
Terrific.
Great.
Was there somebody over there first? Charles, yeah.
I think this should be the last question.
Yeah, okay.
I need to sit down. Okay. My name is David Anderson, and I guess I'm the primary caregiver of my wife who has mental illness. My problem is that in 2 years dealing with this acute situation, I have not been able to find any assistance in terms of being able to diagnose what her problems are. She's been hospitalized 3 different times. We have her on medication. She is at home with me. But as an individual, even though my wife worked for the Department of Mental Health for 24 years, so she's very well acquainted with the workings of the mental health system. And I know that mental health is a real problem in terms of diagnosis and what have you. My problem as a resident and a caregiver, I really have no place to go. Right now, we go once a month to a therapist, and the therapist asks general questions. She has severe mental loss. Nobody has diagnosed this. They've not addressed me to a neurologist. So I feel I'm floundering. I'm doing all I can at home, and I'm keeping her home, and she does well, but I have to do everything. But the problem is, I don't have anybody. She had cancer 10 years ago, and only a 30% chance of survival and made it. But during that period, I knew exactly what was going on, and it really was almost not a burden because we had certain appointments and things and operations and therapy. But I have her at home. She stays at home. I have medication to give her. She, as I said, that was given to her at Beverly Hospital during a stay there. And I sit here today not having any direction, not having anyone I can pick up a phone and call and say I have an issue or something like this.
Yeah.
And I've been told if there's a problem, call the police, and then they will take her to the hospital, and then we'll go through the process, which we've done 3 times. She's doing fine with my assistance. I would like some assistance of some sort, or, you know, trying to find out where I can get it. My philosophy is she needs a neurologist, but
Right.
nobody has told me
Okay.
to take it.
Thank you.
Okay, so the question is, where does he go?
Right.
Well, that's a good question.
Anyone?
So-
Okay.
I'll just have comments. That's amazing that you're taking care of her at home like that. That's an amazing thing you're doing for her. You know, we've talked a lot about primary care and the challenges in primary care. My gut feeling is to say primary care should be the one guiding you to get that neurologist. It's probably more complicated than that, not knowing every detail that you're describing or going through. So I think understanding that there's work that could be done probably through primary care for her would be my first comment. So
Yeah, so
Yeah.
good.
yeah,
Yeah.
right.
And to get an appointment with a primary care physician, to have him refer her
Yeah.
somewhere
Right.
else.
That's exactly the problem.
The-
We have a therapist,
Yeah.
Yeah,
senior healthcare.
Yeah.
I don't want to waste our time going to a therapist once a month and say, well,
Okay.
how are you doing now, and what's going on, and how long am I going to do this?
right.
Everybody diagnosing 3 or 4 things. I know more about her issues because she's with me 24
Right.
hours a day. But
Yeah.
I don't have anyone.
So this story, your story, is very important, and I think we have a panel that actually can pick it up in the second part of our program. So I think clearly you have an important issue that many other people might be facing, and I think we'd best be able to address it by taking a break, having some refreshments, and we'll pick it up with other experts.
Can I just say one thing?
Yeah.
I would just make one comment, and you know, I'm really sorry for your experience, but I feel like that experience is not uncommon across the Commonwealth and across the United States. We were talking earlier. I feel like healthcare pre-pandemic was wobbly. Post-pandemic, it's in the hospital and continues to go into ICU periodically. And for behavioral health, we've never really had a robust system in place. Let's be honest with ourselves. And the best thing you can do, though, I would say, and I do this myself as a mom and a partner of somebody who struggles with behavioral health issues, is just continue to do the advocacy that you're doing and push whenever and wherever you can. It's criminal that you have to do that, but you really have to do that with behavioral health. You also have to do it with healthcare in general right now. You have to be a very educated advocate to help negotiate your way through the system. It's really unfortunate. It shouldn't be that way. But, you know, it's sort of like it's the nature of what's going on in healthcare these days.
Okay. Well, thank you. So we're going to have no more than 10 minutes of a break. We have lots of refreshments in the back and time for conversation, and then we'll reassemble with our panel of experts. Thank you.
Please wrap up your conversations and take your seat. Thank you.
Everyone, if you would please make your way back to your seats. We're ready for the second half and the panel. And the scenarios.
As I drop ball.
If you're part of the second half canon,
So I took notes. And I wrote, send to Dr. Orr.
Yeah.
But I don't know. I probably won't go through because it doesn't seem like there's a lot of young families.
Yeah, so focus on the kids
really?
and grandkids.
I know, a couple, I would say.
was,
See,
if it's
or short, it's a short answer. I mean, it's okay.
Okay.
It's going to be videoed.
I mean, that's,
Okay.
yeah, but it could if it
So I
lasted
should read
200 years, it can last
We're the cause, but wrong audience for me.
So that gentleman said he saw you, Lori Anderson.
Wait, say it again? Yeah.
Wrong audience.
That's what he said. I'm sorry.
I hope this isn't live. It is live.
Hi there, is everybody back in their seats? Have their coffee and their cookies?
I should probably.
Closer? Okay, how's that? Good? Okay. So I hope you all have some coffee and cookies and you're ready to settle in because this panel is going to be really interesting. And I hope everyone has learned something so far that is helpful about our local healthcare community. The second half of our program, in the second half of our program, we have a panel of healthcare experts from a number of different spaces in this healthcare community. We will present 11 different fictitious scenarios for each of them to address, or maybe for a couple of them to address. And maybe some people can jump in and say, oh, I can support that answer too. Dick Prouty will be our panel moderator, and he will introduce the panel. And I'm sure we will learn something from these scenarios, but we also invite you to pose your own questions and maybe scenarios to the panel in the Q&A section after we go through these initial 11 scenarios. All right, so Dick, you want to introduce our panel?
Thank you, Heather. So we have this panel here representing different perspectives, and Kim Perryman is going to be...
Thank you. We have a panel up here representing different perspectives. Kim Perryman is going to be giving us again the perspective of the community hospital. Dr. Orr, Brian Orr, is going to be the pediatric practice perspective. And then Stacy Riley.
It's fine.
Stacy Riley is going to be senior services. School district counseling is Amy Cam. And Jason Andre is the community hospital at Addison Gilbert. So the specific community and the greater community with Kim. So Heather is going to read the scenario, and then I'm going to allocate who will get the first stab at answering, and it's a little different than our rehearsal, so bear with me. Oh, and Vivian Argento, excuse me, geriatric practice, excuse me.
All right, so this is our first scenario. Becky lives alone in Rockport and falls down on her front walk, and then complains of severe pain and cannot stand. Her disabled neighbor calls 911. Becky is worried about her small dog. Oh, I'm sorry, Becky's 85. Yeah, Becky is 85. She falls on her walk, on her front walk. She complains of severe pain. Her disabled neighbor has to dial 911, and Becky is worried about what will happen to her dog. Anybody want to take that on?
I'm going to ask Jason to lead off.
Thank you, and thanks for all of you for being here. So Jason Andre, Vice President at Addison Gilbert Hospital. So I think what's great about this case is there's a lot of collaboration, and as Paul said at the beginning of the day, how community hospitals are the gateway to care. But even to get to the gateway, we have to rely on some of our partners. Beauport Ambulance is a stalwart in the Cape Ann community, would likely be one of the respondents, and they have state-of-the-art EMS. Oh, time's up. No. They have state-of-the-art emergency medical service vehicles that would respond and quickly triage Becky at her site of her home where she is and make the determination in collaboration with a medical director on where to go. So let's say she's brought to Addison Gilbert Emergency Department because that is the closest emergency department for her to go. She would be assessed and stabilized there. Thanks to a generous donation by Lindsay Coolidge, we have a brand new CAT scanner at Addison Gilbert, so she would be assessed for likely a traumatic injury to her head from her fall, as well as x-rays and other imaging for her leg. We would get rapid results due to that new technology. And the doctor at Addison Gilbert would begin to make a care plan. If there was a fracture that required surgery, those images and the medical record are already in the system so that the orthopedic surgeons at Beverly Hospital could start reviewing the case. And if she needed to be transferred for surgery, she would be bundled up and transferred to surgery. If the rest of her care would proceed at Addison, we would proceed there. But let's just say she's transferred to Beverly for surgery. She could be seen by an orthopedic surgeon out of Coastal Orthopedics who has offices here in Gloucester, so that once the surgery is complete, she could continue her follow-up here on Cape Ann. So that includes physical therapy at Addison Gilbert or in her home. Follow-up visits at Coastal Orthopedics, I believe they're at Blackburn, further imaging at Addison Gilbert, as well as potentially being a candidate for hospital at home, depending on what the situation is. And all of that pieces of her being able to be at home would allow her to be closer to her puppy that she's worried about.
Hi, Stacy, nurse manager at Senior Care. I just wanted to add on to that Senior Care does have a pet service, Stay Pet Services, that is income-based. People can get free. Sorry about that. People get free pet boarding, dog walking, things like that. Stay Pet Services through Senior Care.
Okay, so our next scenario is a 3-year-old. His name is Ronaldo. Ronaldo arrived with his mother from Central America about a year ago. An uncle has recently come to visit. Ronaldo develops a rash on his face and his eyes hurt. His mother has no health insurance or a green card. She is not sure what to do.
Brian Orr, we'd like to have you start.
Well, I don't know what to do about getting her to me, but my office, we have 2 people who speak Spanish in my office. We take care of a lot of people from Central America and Mexico. We also have, I'm learning enough Portuguese, and I'll have a lot of Portuguese-speaking patients as well. And interestingly enough, a lot of people from Central America do have a lot more allergies up here than they would in their homes in Central America, and a lot more eczema. So this looks like a classic case of one of those. So I would hopefully get that person to come to my office. We would help them to navigate to get health insurance, because anybody can get health insurance in Massachusetts. And in the meantime, we would take care of his problem on the immediate side before he even got insurance. I hope that would help him out.
And the no health insurance or green card?
For me, that doesn't matter.
So
for my office.
Right, and so that would go, we think. Yeah, that would go to Maggie.
We could also see the family at the health center, and regardless of whether or not they're, they're legally in the country or not, doesn't matter to us. We would see them. And we're actually the only outpatient places where people like that can be seen, and we can bill what's called the health safety net. So we actually get paid for those visits. So, and we would help mom and the rest of the family get enrolled and make sure that they're seen.
And we've referred...
Like Gloucester Family Health.
Yeah, and we've referred families over
Yes.
to them as well.
So you guys collaborate on it. That's great.
If I may. Just one final point on that. I think that's an incredibly important point to know, is that we have pediatricians and provider offices that are willing to do that, and the health centers to do that. Because obviously the emergency department will do that as well, but in a scenario such as this, where it's not a medical emergency, but people don't know where else to go, they'll come to the emergency room. So to be able to rely on our partners in the community to provide low-level outpatient care helps reduce some of that significant burden.
Okay, so our next scenario involves Pamela, who is 72. Pamela receives a letter in the mail telling her that her Medicare supplement insurance is ending in April because it was tied to her ex-husband's employment. She has diabetes and is worried about how to get new insurance.
So who would like to answer this?
Stacy, is it?
Well, unfortunately, Senior Care does not help with Medicare insurance. We would refer them to a Shine counselor. If it was Medicaid, we do have a Medicaid specialist that helps people with their applications, but we would definitely send them probably over to Addison Gilbert.
Hi, me again. No, she is not. Safathia is one of the Shine representatives, but there are 2 other Shine counselors regularly at Addison Gilbert Hospital. If you call the main Addison Gilbert Hospital number, they can connect you to that department. They'll make an appointment with you. They're usually 45 minutes to an hour long. So we don't really have walk-in ability, but on occasion they will. You just might have to wait a little bit, so it's better to call and make that appointment, but we will see you.
All done?
Yeah.
Okay, so
next.
Our next scenario involves Richard, who is 38. Richard works on fishing boats and sometimes in fish processing. He has chronic back pain from an old injury and began taking prescriptive painkillers. His girlfriend worries about his drinking and thinks he has addiction problems and urges him to get help. He doesn't want his supervisor at work to know and has no regular doctor.
So we actually thought this was a question for Maggie. Just like an easy one.
Our patients. So certainly he could come and establish care at the health center. And actually, if he was if it was determined that he was addicted to opiates, we could induce him with Suboxone the same day he came. And we could also establish him with primary care. All of our primary care providers have what's called an X license, so they can prescribe Suboxone. And we have folks who can also can prescribe for alcohol addiction as well. So we have a comprehensive program, and it sounds like it said that was a very familiar scenario to me because it sounds like not a small number of our patients.
Great.
The privacy part, meaning he wouldn't want to bill his insurance company? But his employer wouldn't find out of his insurance company. He was using his insurance. I'm not sure what the issue is.
He doesn't want his supervisor at work to know, and he has no regular doctor, so.
Well, we would never, we wouldn't be, plus we would try and figure out when he's available, which is always kind of a problem because folks tend to go out at hours, then they want to come in and be seen, but we would work with him in terms of his schedule. Like I said, in terms of Suboxone specifically, people can get induced on the weekends, if they want, by our providers, so.
Good to know. That's good. Great. Anyone else need to respond? Feel like they can respond?
The only other thing is that any new patient who comes in, we have to introduce the idea of privacy, that all records are private. We can't disclose information from a private medical visit. So all records, all information is private. We couldn't disclose anything to a workforce place, an employer, school, anything. Yeah.
Okay, so our next scenario involves Elizabeth, who is 8 years old. Elizabeth lives with her parents in Gloucester and has entered the 4th grade at Beeman Memorial School. She has recently said she hates school and refuses to go several mornings each week. Her mother has chronic health problems of her own and is often too tired to argue with Elizabeth. She has now been absent 25 out of the last 80 school days.
Okay, so I'll take that, I think. I'm Amy Kam, I'm the Director of Mental Health and Social Emotional Learning for the Gloucester Public Schools. And post-COVID, school avoidance and chronic absenteeism has been a priority in our district as we've seen the rates increase. In that, we have partnered with Attendance Works, which is a national consultant, and we have shifted all of our attendance policies from punitive to much more relational. In that, we have changed from an attendance supervisor to a family engagement specialist. She is bilingual, and we, in order to address this, we would definitely go to home visits if they wanted. We would look at what is going on. This is very vague, so we're not sure if it's anxiety, whether she's scared to leave mom because of the medical fragility, whether there's a social issue, but based on that, we would create a plan. We also, just for those of you who are listening who might be parents or grandparents, we have also established school-based teams at every school, attendance teams, and we look at data, not just individuals like Elizabeth who are struggling, but more aggregate data to come up with more systemic interventions earlier. So I don't think in our new system, this would be like, I don't think our first intervention would be at 20 whatever absences. So that's the good news. If our efforts didn't work, because they don't always work, and the home visits or other different strategies, we also consult with Lynn Lyons, who has really helped us support kids struggling with anxiety in amazing ways, and we have them here also talk to parents. We would refer to all of our partners. So we have Leahy, IHT, in-home therapy, if that piece would be helpful to support mom and dad. It sounds like both are in the home. Or Care Solace is another partner that we pay for. It's 24/7 connection to mental health and substance abuse treatment for every one of our students, every one of our students' family members, every one of our staff, and every one of our staff members, and it connects to necessary services. So if that's what they felt they needed, possibly a family partner, and there's Elliot. So it depends on what was going on, but that's how we would address it as a school.
I just have a follow-up question.
Sure.
So as a former school teacher and somebody who's been communicating with people who do assessment tests for special needs situations, this child would not be diagnosed as special needs or would be?
So attendance isn't a qualifier, but we would certainly see if there was a learning issue going on. We don't know why she's avoiding school.
Yeah,
it's
I
not
can-
clear.
I can chime in here.
Okay, go ahead.
We, the pediatricians in the area have been working closely with the schools to work with school absenteeism. When a child comes to us as pediatricians for school absenteeism, there can be a myriad of things going on. There could be problems with the child and anxiety and health issues. There could be problems with school. It could be anything from bullying to school achievement issues. But it can be a problem at home. It can be a problem that if there's an illness with grandparents in the family, or in this case, we said the mother has a chronic health problem. A child could be afraid to go to school because they're afraid to leave the unhealthy mother at home. So this family might need simple help of therapists to help this child get through the mother's health issues. So we have to really scratch the surface and find out what the issue is of why this child is missing school.
Thank you very much.
Okay, our next scenario involves Gloria, who is 60 years old. Gloria lives alone and receives rental assistance from the Housing Authority. She has chronic joint pain, takes pain pills, but cannot find a doctor who will take her Mass Health insurance. She is computer challenged and has difficulty organizing her medical records and prescription drugs.
Hi. Well, as far as the doctors who provide Mass Health insurance, we don't usually help with that, but we do and can refer them to the Gloucester Family Health Center. As far as medical prescription drug issues, computer challenges issues, we do have a medication management nurse. If somebody wants help with maybe a medication dispensing machine, a nurse to come in and fill a pill box, we can also help with that. We do have somebody in-house that helps our consumers with tech issues. He can go out, we can provide them with tablets, laptops, teach them how to use them. There's also, the Council on Aging who do have computer classes that some of our more mobile seniors have gone to.
I would also say, if the patient became a patient of Gloucester Family Health Center, we have nurse care managers this person would probably likely pop up on a list for that person to be, for the nurse to regularly check in with her to make sure she's doing okay and walk her through her whole sort of protocol around prescriptions. And we would also arrange for, transportation if that was an issue for her to come to visits, or we would, work with her in terms of telehealth, help her to figure out. We can do telephonic, but, try to figure out a way to get her a phone and help her work through that too, so.
That's good to know.
All right. Anyone else need to respond or feel like they can respond? Good? Okay, so our next scenario involves Dieter, who is 70 years old. Dieter is a German citizen who has been spending the summer in Rockport with his wife. He experiences severe pains in his esophagus after eating and seems to have difficulty swallowing sometimes. His wife asks their neighbor where to go for help. She also tries calling a gastroenterologist, but cannot penetrate their appointment system.
We're going to ask Jason to handle this.
Sure. So similar to the first case, especially for those of our population who come here in the summers or vacation here, typically the front door to healthcare is urgent care or the emergency department. We have urgent care up at Gloucester Crossing and obviously the emergency department at Addison Gilbert. When reading this scenario, the esophageal pain jumped out at me as an emergent situation where this person should go to the emergency room because he could have a severe bleed in his esophagus or could be having a heart attack. Esophageal pain and difficulty swallowing is a symptom of this person potentially having a heart attack. So 911 to the hospital is the way to go. Again, this is well within the capabilities of the Addison Gilbert Emergency Department to assess the patient. They have a piece of equipment called the GlideScope, which they can give the patient a little bit of a sedative and look down his throat to see what's going on, in addition to do an EKG and other lab tests to see if he's having a heart attack. The other part of this, as this patient is visiting from Germany, is a potential language barrier. We have a full-service interpreter service program at all of the BILH facilities, and part of an investment in the last several years were iPads that we have in all of our clinical areas that offer almost FaceTime with a medical interpreter so that he could speak German to a medical interpreter with his care team and easily understand what was going on between him and his wife and his friends in Rockport. And then if there were follow-up care, we would set it up with our gastroenterologists that visit the specialty clinics at Addison Gilbert.
Thank you, Jason. Pretty amazing. Next.
All right, so Henry is 14 years old. Henry recently started Gloucester High School, but is having trouble completing assignments and cannot write coherent paragraphs. He also acts out occasionally and has few friends. His teacher is concerned about his several problems and notifies his parents, who don't respond.
Okay. So obviously, Amy, yeah. So obviously parent involvement is ideal, but we can do things at the school level before that, before re-engaging or trying to more actively engage them. I think there's multiple issues going on and we're not really, again, we have to assess for what's really going on. We have to rule out a learning issue. We have to rule out a mental health, like executive functioning or ADHD issue or anxiety. We also may need to rule out a social skill deficit for the lack of friends. It's not clear, is it an 8th to 9th grade transition issue? He's just not aware of what's available or how to connect to those things. So what we would do at the school level is every school has a child study team or a student study team. It's called different things in the different levels. And we get feedback and data from all the teachers so that we really understand what's going on. Is this trouble writing a paragraph, I think, across the board? Is it certain circumstances? We try to understand that, and we create an intervention plan, a response to intervention it's called. We would also possibly put him in a tier 2 intervention, which is more targeted intervention. So every student at the school gets tier 1, which is what every student gets in a general ed classroom, but this is more targeted, sometimes pull out to help. We may do a therapeutic mentor for the connection piece, especially if it's a social skill deficit. We would reach out to a community partner. And then in terms of the attentional anxiety / executive functioning or whatever's going on there, I always call Dr. Moore. And there's something, I want the community to know, there's something called a MCPAP, which is Massachusetts Children's Access to Psychiatry. And because there is a lack of psychiatric care for children, that is a tool that Dr. Orr often uses. You can talk more about that?
Yeah.
Yeah.
So it's out of Mass General, who has really been a major center for child psychiatry in the Boston area. And they have an access program that within a week of us calling them, they will contact and provide care, psychiatric care, to a child and family. Many times, then sending us an actual summary and a prescriptive guidance as to what we should do in a stepwise progression for each of those students or patients. So it's a great program for us to have access to as pediatricians.
Yes, we have a school-based health center as well, yes.
Yeah, the school-based health center is, as Maggie gave her presentation earlier, Gloucester was kind of missing from the list, but it's not. It's operated through Addison Gilbert Hospital in collaboration with the State Department of Public Health. Maggie and I and Amy have had multiple conversations over the years on making sure that there's some alignment, but also to that, make sure those priorities are aligned with the students in Gloucester.
I'm just curious, Dr. Orr, so when Mass General provides this service, is there billing or is this just free?
That's a very good question.
It's billed, I think it's billed through their insurance.
Through their
Yeah,
insurance.
through their insurance. It's like a one-time psychiatric diagnostic eval.
It's an evaluation.
Yeah,
Yeah,
it's an evaluation.
But you should never ask a doctor about billing.
I apologize.
Can I just ask, did you address the fact that the parents didn't respond?
Oh, so we'll get to that.
So we're trying, okay.
So we're trying to support the kid first. No, we're, as we're doing this, we're, asking the parents in. Right now, it sounds like there was maybe one attempt by a teacher, but administration and a guidance counselor would probably get involved. We have district clinical staff. Gloucester is very fortunate. We have a superintendent who really values mental health and social emotional learning in our district. And we have about 30 clinical staff throughout the schools, adjustment counselors, school psychologists, and BCBAs, behavior specialists. So we would be doing home visits if they didn't respond, wellness checks. We just would go more intensive efforts. Yeah, but thank you. Yes.
Yeah.
Yes, I thought, just a comment, I thought it was interesting in the recent budget analysis, the superintendent did not cut the social emotional counselors in the elementary schools, which I thought that would never have happened when I was teaching school. They would be first to go. And I think that it's a very interesting assessment. Next.
All right, Gail is 73 years old. Gail lives with her boyfriend, Paul, age 78, in a house she owns. Paul is worried because she has fallen a few times and forgets to pay utility bills. Last week, she couldn't remember where she parked the car at the North Shore Mall. He thinks she may have health or memory problems, but does not want her adult children to find out.
So this is Vivian Argento.
Yeah, so the first place to go would be to primary care. It doesn't say in here if she has a primary care provider or not, but that's usually the first stop to kind of check out what's going on. There's some red flags around memory loss with utility bills and losing the car, or not being able to find the car, and she's falling a lot. The primary care provider would likely look at her medical history, the medication she's on, see if she's had any recent blood work, or order some blood work to rule out an acute problem that could be affecting memory and balance. Depending on what they found, they would treat that. Alternatively, if these seem to be more chronic problems, the primary care providers could send Gail to the Center for Healthy Aging, where we have comprehensive services to care for older adults who are struggling both from geriatric behavioral health conditions and from geriatric medical syndromes, in this case, the syndromes of memory loss and recurrent and frequent falling. And again, that would entail a comprehensive, what we call a biopsychosocial assessment. So we have all of the assessments start by meeting one of the social workers at the Center for Healthy Aging. They take a very comprehensive psychological and social history. They would ask a little bit about Gail's relationship with Paul, her relationship with the adult children, try to understand the nuances of that situation a little bit better. Would then additionally do some cognitive and behavioral health assessments. And then shortly after that assessment, Gail would come in this scenario, it most likely be seen by the medical geriatrician, which would be myself or Dr. Peliquin, to review all of the information that was collected by the social worker. Again, explore a little bit what's exactly going on, what's Paul seeing, what's their relationship, what's the relationship with the adult children, and see if we could put this together for them, and offer them some treatment if treatment is necessary, or to talk with Paul about what kind of supports Gail might need. In terms of the adult children finding out, again, I think Dr. Orr mentioned we have pretty strict privacy rules. We don't routinely share care with anybody that our patient, that Gail in this case, wouldn't want us to. So if Gail says, I don't want my adult children to know, we wouldn't necessarily have to talk to the children. I certainly would explore that relationship a little bit and find out what's going on there. As Gail ages, she might need the help of her adult children. And so trying to understand what the concerns are about the adult children, finding out would be an important part of the assessment, and our social workers help with that as well. And sometimes when there are interpersonal, relational problems within a family, the social workers can do some family therapy and counseling to help work through some of those sticking points. So it depends a little bit on the scenario. If Gail were to become completely incapacitated, and one of her adult children or her adult children were a healthcare proxy, there may be some scenarios at which point the children would get involved with care, but that would only be with either Gail's consent or with her inability to make medical decisions, and only with the person that she had previously selected to make those health decisions. What are the others? So we want the children to find out. Yeah. And then, I think the other thing here is, depending on what the assessment shows, we'll often make referrals to senior care to help assess what's going on in the home, what kind of care services are needed, and what resources are available in the community to help support Gail so that she can age in place in her home, hopefully with the support of Paul. It sounds like he's interested in sticking around, so.
Yeah, and not only for Gail, but we also do have a caregiver support program for Paul if he needs it as well. And as for Gail, if she needs help in her home with any personal care or help around the house, we have money management, we have medication management. A care manager would do an assessment and see what her needs are, and then we'd go from there. Everything is tailored to what our consumers' needs are at that time.
Thank you very much. Go ahead.
All right. William is 5. William lives with his parents in Gloucester, and in the late spring begins to sound wheezy and has trouble breathing. His parents take him to the Beverly ER on a Saturday night, and he receives treatment that stabilizes his breathing. But the ER doctor says he could be allergic to something.
This is Brian, Dr. Orr.
This is my routine every Monday morning. So, you probably
And they
missed
just-
it, yeah. I never have a case where child was seen in Addison Gilbert ER or Beverly ER that I don't know about. Many times I get communication with the physician from the ER, and this child would be followed up immediately the next day. And as far as allergy, either we could get this child to an allergist, or there's some allergy testing we can do through blood work that we can order. So this is a common scenario and very routine for us, but it's really the communication between the hospital and the primary care pediatricians in the area is excellent.
Anybody else?
All right. This is our last scenario. Maria Carmen is 43. Maria Carmen works cleaning houses and a nurse. I'm sorry, start that over. Maria Carmen works cleaning houses, and a nurse told her that she is at high risk for type 2 diabetes and to modify her diet. She has some difficulty with English and is not sure where to find the recommended foods or how she can afford them.
Well, we had here Maggie or Kim.
I'm looking at Maggie, the community resources.
Yeah. We don't have a nutritionist on staff at the health center, but like some of our nurses may get involved and talk about diet and the importance of exercise, but we don't have a specific nutritionist or dietitian on. But I think that there's a lot that can be done within primary care to help her.
Well, I think
Yeah.
Jason.
So
Yeah.
one of my other hats is I'm on the board of the Open Door Food Pantry that serves Cape Ann and a lot of the North Shore. They have a medically tailored grocery program, and that serves exactly what this scenario lists out. So the Open Door employs nutritionists and dietitians. Some are bilingual to help Maria, and would work with her to understand what her diet needs to be, but also provide the groceries. So it looks like she cleans houses, so maybe is at the lower end of the income and economic level that the Open Door can actually provide that healthy food to her. Mary Lou, I think, had to leave, but we have some Open Door medically tailored grocery packets that if anybody's interested in, I think they're around here somewhere. If not, they're on the table in the back, great. It's a program that the Open Door is looking to grow and really work in collaboration with the hospital on as well.
Well, that's pretty amazing. I have the impression people are learning new things here, not just in the audience.
Mm-hmm.
So that's one of the things that we thought might happen. At least I did. We're now going to go to questions and answers. We're going now to the questions and answer session, Elizabeth. Yep.
Dick, I think, should we ask David, is that your name? Did you want to pursue your question, or do you feel like that was satisfied on the last section? Okay. Okay, great.
All right, so the intent here is, about 15 minutes of Q&A before we wrap up. We'll see how it goes. And you can ask a specific follow-up to one of the scenarios, or you can just ask a general question about the topics the scenario is covered. So we've got people in the audience. Charles has got a...
Being of an age with the baby boomers, I'm wondering how society is preparing for the onslaught of intense medical demand and end-of-life demand that is approaching in the next 5 to 10 years.
That's a perfect question.
Well,
Great question.
I'll take that one. It's a challenge with healthcare as we face the workforce challenges, but we are seeing high demand for hospital services, and we anticipate that need is going to continue, and is a large part of why, as a hospital system, we're exploring and innovating in spaces like hospital at home, where we can provide care for patients at home to make sure that need is there, making investments in the primary care infrastructure. There are not enough geriatricians to care for all of the baby boomers as they age. Across the nation, there's 7,000 at last count of people who are board certified in geriatric medicine. I would say you're actually fortunate in this region to have 2 board certified geriatricians who practice in Gloucester. It's an uncommon scenario. And so a lot of it is going to be workforce training. We do a lot of work, particularly with our new nurse graduates, to train them in the care for the older adult. We've been working to create a dementia-friendly environment, or dementia-capable environment in the hospital, and an age-friendly health system, again, which is workforce training. And for dealing with end-of-life issues, we are actually currently piloting a project with multiple members of a medical team on increasing serious illness conversations. So having honest conversations with people earlier in the course of their serious illness to find out what matters to them. So not even talking about the end-of-life issues, but just what are the factors that are most important to you, and the goals that are most important to you, so that we can make sure that we're tailoring all of your healthcare to meet those goals. And we're using our social workers, our chaplains, and hospitalists to support those conversations. And then using our electronic health record to make sure that we are capturing that information and that it's transmitted across the spectrum of care that's easily accessible, so that if you have that conversation with one of our teams in the hospital, your primary care physician can easily see it. And we work on communication with the primary care teams constantly. And if you come into the emergency department, the emergency room teams can see that information, so that we can continue to build and iterate on understanding who you are as a person and how your health conditions are affecting your ability to have a quality and functional life.
Next question, Elizabeth.
I'm 79 years old, and I feel I have all my mental faculty, and I've had a suspension of a license. And I did everything that was supposed to be done legally. I never did anything, I never drove the car or got caught with it, which you can go to for 10 days, and then whatever you lose on that. I read all of the bylaws of the Registry of Motor Vehicles, and the requirements they wanted, and the back and front of all the pages, like if you have drunk or if you committed murder or something, it might be 4 days, 5 days, but this policeman gave me something called medical treatment, and it has indefinite. There's no thing which shows how much or not. But after reading some of the papers that I found on my medical record, I found that a lot of things were wrong. At the first thing, I did everything that they wanted. I got the eye test, which really isn't medical because they do give you an eye test with the RMV anyway, but I did give them my doctors. And the next one was supposed to be psychological or a doctor. And so I went to my primary care physician.
Elizabeth, hold on. Can we turn this into a question about transportation? Because
transportation. No,
yes.
But the thing, it's not transportation. It's the fact that she did not do something which I told her I had read in the bylaws, that if she's a medical doctor.
We're not here to solve a particular problem.
Yeah.
We can't
But
solve a particular problem right
I
now.
tried to get in touch with this
Well, we understand, Elizabeth.
Read me from the
Yeah, we understand.
Okay.
Well, we can't solve that right now.
Okay,
Sorry.
I have a question about transportation, but Helene has, Karen.
Okay, excuse me, because I have an important resource to share. And this is, my name's Helene Levin. I'm a mental health counselor here in Gloucester. Oh, can you hear me now? Okay. And this is directed towards the gentleman who spoke earlier, but everybody. There's an organization called National Alliance on Mental Illness, NAMI, and there's a Cape Ann chapter. There's support groups for family members of people struggling with mental health issues. Their website is namicapeann.org, and there's also a national hotline number on that website. And also, in case the gentleman who spoke earlier didn't get a resource about a neurologist, you don't need a primary care physician referral for a specialist if your wife is on Medicare.
Great. Charles, there's this one back.
Question up back.
Hi there. So we walked through the different scenarios of individuals in Gloucester, and I think we talked about like that they could go to a primary care provider and then be able to get access to their services. How long is it actually taking though for an individual to get into that primary care provider? And from like the community health center standpoint, from my understanding, there's a line, like there's a wait list there too. Oh, woohoo! Yay! Yeah.
And you'll find that that's the case for a lot of primary care offices
Yeah.
right now.
And
There's
so I
just
guess
the
my
demand is skyrocketed.
So I guess my question is, collectively as a community, knowing that getting to primary care, it can be a challenge, how do we get people to these other services, open door, actioning, all that exists when they don't have that individual, that initial individual that they're able to get to in a timely manner?
Sounds like a Jason question.
So a couple answers to that. The primary care field is changing to address the backlog. The state of Massachusetts recently, and Kim might know a little bit more, is starting to allow advanced practice professionals and nurse practitioners to act as primary care providers without supervision from a physician after 2 years of practice, I believe.
Yeah, that
so
law passed during the pandemic.
That law passed during the pandemic. So that will help seed the workforce of the providers. So you may have to start thinking about the change in dynamic of primary care and seeing that singular physician, and it may become more of a team approach where you see an advanced practice professional or nurse practitioner, or you may be assigned to a single nurse practitioner's panel. I'm married to one. So that's one way. The other thing is symposiums like this, and all of you coming, is to share the word about what Maggie's doing at the health center, what Amy's doing at the school, what Brian's doing in his practice, what we're doing in the hospital. We put articles in the newspaper, press releases get picked up, there's letters to editors that I think some of you have written or your co-residents have written to talk about this issue. So the more forums, the more vocalness that we can have out there to let people know of all of these wonderful services that are here in Cape Ann, not just in the North Shore, Massachusetts. Here in Cape Ann is important.
I think the question was specifically, how does someone get to these different things if they don't have a primary physician, and who coordinates their doing that? Is that something that the person has to do, or is there any point person at any institution that could help?
Well, for Open Door and for many of the services, it's people self-refer. You don't need a primary provider to we can give that information in my office. I have things posted up.
Can I add something to that, though?
Yeah.
Is Action still in the room? So there's a function called a community navigator, right, that can sort of help pick through all of the different services and what's required. And I think it's a gap in our city. We don't have enough of them right now. And so people have to know where to go, you know.
Yeah.
And if I can just add on to that question, I think it's really interesting because I know Addison Gilbert is about to go through the Epic upgrade, and, you know, Olive Leahy is correct, where you're sort of, you know.
We're already on.
Oh, you're already on?
Yeah, we're done.
Oh, great, congratulations.
8 years ago.
But, okay, so now I'm wondering with interoperability, are you all considering expanding interoperability into other organizations beyond your hospital system? So really taking advantage of the technology that's out there right now to allow you to communicate immediately, so you don't have to call the doctor, you don't have to call the school, you don't have to call a local mental health provider. Everybody can just get in and get what they need. that would also help solve and streamline a lot of the access problems. Are you guys working on that?
Could I ask you, because I happen to know about Epic because I had a dinner with somebody who was friend of the billionaire who invented it and made multi-billion.
A woman.
Really?
So but I had never even heard of it. So I don't know how many of the audience even know what Epic is.
I have legendary stories about it.
So Epic is the name of the electronic health record that we use in our system. We've been on that system, I think it's like 8 years. There are different upgrades and changes that happen, continuously. So I don't know if that Dominique, may be something you heard, but it's meant to be a communication vehicle for primary care, subspecialties, ER care, inpatient care. So that's the beauty of that system. Are there more possibilities? I'm sure there's endless possibilities, and that will continue to grow, particularly around, social services, mental health. Do you want to?
I mean, it's available now, right?
Yeah,
the
I don't-
technology is available right now.
The
to
technology
be able
is,
to share.
yes, the technology is available right now. I'm not familiar with all of the details because I'm not on these committees, but the BILH system is looking at various tools that would support that kind of interoperability. The EPIC tool allows us to screen for the social determinants of health, and through the tools that they're looking at, allow the providers in the hospital using EPIC to make referrals to outside organizations. And they're looking at the different vendors. There's a couple of different tools. So I do anticipate in the next year or two that's going to be rolling out with more fluidity to create those connections, to make those referrals directly, which I think is what you're...
And there,
Just automate the referral process.
and there already are links to some of the larger healthcare organizations. We can see Mass General Brigham records, and they can see ours as well, so that if people do bounce between systems, in the health center. Yeah.
Hi, I'm Marcia Hart, and I worked at the hospital a long time ago in the 80s, and then I spent 31 years working for the visiting nurses in this area. And what I did for a job was answer a lot of the questions that were posed. And I'm very concerned because there aren't any visiting nurses or that organization represented here, and absolutely no one referred to them from all of you. And my job was to answer those sort of questions, and then I would refer to all of you, the patients that I had, to get the supportive services in the community. And I retired about 6 years ago, and I'm wondering, has the visiting nurse organizations disappeared? And have they been weakened by the pandemic? I know that some of that happened just as it did in the hospitals, and that going into people's homes was a large risk rather than working in a facility that people came in and cleaned before you went to work. So it could be that they aren't servicing the community as they did when I worked there, but can you tell me?
Sure. So I would say that visiting nursing is alive and well for those patients appropriate who need that care in their home. Of course, they've been impacted by the pandemic and the workforce challenges, but it's definitely a service that we discharge patients with. Visiting nurses are alive and well. It was an interesting thing you mentioned when you had been a nurse up till 6 years ago. And one of the things when we were talking about innovation in workforce is starting to think about how we reach out to folks who are retired or not working in acute care, and how do we use their skills virtually. So you'll start to hear more about virtual nursing and virtual care, and it's really about giving the novice workforce some other tool to connect with someone who has more experience or years of care.
And something else we didn't touch on is the role of the LPN, which is coming back in full force across the industry as we look to solve these workforce challenges where, before the pandemic, everybody wanted bachelor's trained nurses. Now we want people with, I think, what did you say? Recruit for the attitude, train for the skill.
I would also I would add to that, certainly visiting nurses are still, that service is still alive and well. What I would say is that in the home health space, however, what we have found is that there are a lot of really bad actors in that space. So we're very careful and selective about who we work with. Both hospital systems have terrific programs, but there are these companies that come and set up and they offer jobs to people in low-income neighborhoods, and patients present with, I want to get, home health aid. And they're just making money. So just be wary of visiting nurse, yes, but home health as appropriate and with a reputable agency.
I think we're just going to wrap it up now, and we're closing at 4 o'clock.
Can I ask one question real quickly? I don't think people have addressed transportation. I do have what if someone can't get on Cape Ann, can't get to a doctor's appointment? They don't drive.
That's pretty hard to do.
Well, I know for us it's limited because it's for people 60 and over, but we do have a volunteer medical transportation program with senior care. It is just for medical transportation, and you do have to be able to get in and out of the car by yourself. We can't accompany you into the appointments. That's one option. And then for folks that do need help and are our consumers, we can have their workers go with them, their home health aides, their PC workers. They can drive them, they can go in with them, they can push their wheelchair, take their oxygen, whatever they need.
I can also add to that. So, of course, we have CADA, right? And so CADA has dial-a-ride and or on-demand. So if you're, it's $2, and you can, call the day before and get a transport anywhere across our 7 sort of sister cities.
You didn't answer.
Okay. So there's, it's complicated, I think, sometimes. And there's also, if I could just elaborate a little bit more.
Yeah, so we're going, Elizabeth, thank you. We're going to wrap it up now. So
I just wanted to call out one other thing. So beyond CADA doing that for on-demand, if you have disabilities as well, it's also a service. They also have, if you are walking and you're flagging them down, they'll take you anywhere in these areas. You can get a prescription for transport. And if you have a prescription for transport, there's a service, PT1 I think it's called, that you can call and they will take you anywhere, even all the way down to Boston if necessary, correct? I know that all of our Mass General and Leahy programs have vans that will pick you up from North Station and take you to the centers of excellence if you have to go all the way into the city. So there are solutions, but there are also still gaps.
So
I want to talk to...
Yeah. So we want to thank everybody for attending and thank our guests for their volunteer time. Thank you so much.
Thank you.
I miss seeing you over Zoom, but it's also good we don't do that. Right? Yeah.
Thank you.
Thank you, Jason.
Nice job.
So good.
Yes, it was real.